Okay, great. Thank you so much. All right, so I'll start again actually from the top then. Let me take over. Okay, sorry about that. I was trying to use my own device, and I guess the guest Wi-Fi is just not having it. Okay, so from the top. So thanks all for coming. So I'm going to present for Graham an update on lung cancer, the diagnostic landscape, novel agents, and some toxicities for the non-oncologist. Because we're all I think, in some way or the other involved in the care of patients with cancer, whether it's the diagnosis and workup or the management of complications from the cancer or treatment. So I think it's a very relevant topic. So hopefully in the next 30 minutes or so, I hope to review the current lung cancer statistics and basics, the current diagnostic and treatment landscape of lung cancer with a focus on non-small cell, and some of the updates on the current outcomes as to how well patients do nowadays. And then also to review some novel agents and potential toxicities that may lead to hospitalization. Okay, so let's start with some basic stuff first. So incidence, lung cancer is still the most common cancer in Canada. So this is from the Canadian Cancer Society. In 2023, it was estimated that about 31,000 Canadians were diagnosed with this disease, evenly split between males and females. And not only is it the most commonly diagnosed cancer, it's actually the most common cause of cancer death, with an estimated mortality of 20,600 patients. So that's about a mortality rate of 66% with this diagnosis. And it's higher than colon, pancreas, and breast combined, actually. So still an area of unmet need for sure, with room for improvement. So just back to some medical school basics. We all know that tobacco exposure and smoking is highly associated and is a risk factor for lung cancer. There's a lot of interesting question about vaping and e-cigarettes. From what I understand and what I've seen or looked up, it's not firmly established yet as a risk factor, but there certainly is biologic plausibility. So I think as time goes on, we'll have more data about that. Occupational exposure obviously is associated with risk of lung cancer. So people in the construction, mining, automotive, ship industry, increased risk, radon exposure for sure. Ionizing radiation, so radiotherapy for other reasons, radiation from diagnostic imaging. And in the Japanese population, they found that there is also increased risk of cancer from atomic bomb radiation. And of course, cancer is still a disease mostly of older patients, although of course there are exceptions to the rule. So is there screening for lung cancer like there is for breast, colon, and cervical? Yes, there is actually. So there is guidance from the Canadian Task Force on Preventative Health, but it's not for everyone. It's not for the average patient. It's for high-risk populations only. And in that study that established this, it did show that it can reduce mortality, although this is a weak recommendation based on that low quality of evidence of that study alone. So here in Toronto, we actually do have an Ontario Lung Screening Program based at UHN. So this is a referral form you can download and Google yourself quite easily from Cancer Care Ontario. And so in terms of eligibility, so they're looking for patients who are a bit older, so 55 to 74 years old, with a 30 or greater pack year history, and are still smoking or quit within the last 15 years. That's the eligibility for the study that was done. If you look at the actual referral form, they're a little bit looser, so they only need to have a 20 pack year history, and it doesn't matter when they quit. And what is the actual screening protocol then? So it's a low dose chest CT done annually up to 3 consecutive times. And they do, I'm just gonna look at the chat messages. Oh, okay. Right, so it should be done at a center with expertise in diagnosis and treatment, so people who are experienced reading these scans and has thoracic support. I should also mention that chest x-rays are not recommended for lung cancer screening. Okay, so back to some basics again. So how do patients with lung cancer present? Obviously, it depends on when you catch them, at what stage of the natural history of the disease. So obviously, when it starts off as a single cell that's become aberrant, patients will be completely asymptomatic. It's not until that cell starts to replicate and form a tumor that you may get some non-specific symptoms, cough, dyspnea on exertion, chest discomfort. And as that tumor grows and invades locally, then you can get other symptoms like hemoptysis, chest pain, dysphonia, and dysphagia. And of course, what we probably all see here in the hospital is when it's quite advanced, you can get cancer cachexia, anorexia, weight loss, and weakness. Night fevers and night sweats not typically seen with lung cancer. That's usually more in the rapidly proliferating cancers like hematology or small cell. But you can certainly have consequences of metastases. For example, if there's bony mets, you can get bony pain and fractures, brain mets, headaches, and seizures. Pleural effusion is very common. SVC syndrome, Horner syndrome with the triad of meiosis, ptosis, and hydrosis, brachial plexopathy, and cord compression and paralysis, which is quite devastating. And unfortunately, I've seen a number of that already on the wards. And then let's not forget that there are also paraneoplastic phenomena. So clubbing, hypercalcemia, and hypertrophic osteoarthropathy more commonly seen in non-small cell, whereas the more the interesting and kind of strange paraneoplastic syndromes are, such as Cushing's, Lambert-Eaton, and encephalopathy is seen in small cell. So the gold standard for diagnosing lung cancer still remains a tissue biopsy. And so commonly we get, IR-guided core needle biopsies, which is appropriate if the lesion is quite peripheral and close to, say, the chest wall. But of course, if it's more central, another approach is to do endobronchial biopsy and lymph node sampling. I just want to comment that, we oftentimes do pleural fluid cytology, after a diagnostic and therapeutic tap, lavage and bronchoscopy, but really this is not sufficient anymore for proper treatment planning, because rarely there's enough yield to make a cell block for all the molecular tests, which is kind of the focus of one of my objectives today. So while cytology can diagnose carcinoma, we really need a little bit more information than that nowadays to form a proper treatment plan. Something that may be coming down the pipeline and becoming more mainstream is something called a liquid biopsy. That's essentially just a peripheral blood draw for circulating tumor cells or cell-free DNA. And I don't think this will fully replace a tissue biopsy because there are already studies that demonstrate you need a high tumor burden generally to get enough sensitivity to detect circulating tumor cells in the peripheral blood. But there certainly is a niche for it, particularly for monitoring treatment response. Doing a peripheral blood draw is much simpler than having to arrange for a biopsy, for example. And of course, once you've diagnosed cancer, imaging for staging is also very important. So for lung cancer, if it's not clearly metastatic, all you really need actually is a PET scan and an MRI of the head. And you don't actually need CT scans, but of course, we have to think more practically. There's only two PET scanners in Toronto, and wait lists can be long. So I think it's still quite reasonable and practical to get CT, chest, abdomen, pelvis. An MRI of the head is preferred over CT as it's more sensitive for smaller lesions and leptomeningeal disease, and as well a bone scan. And just one note, so if patients have bilateral metastases or pleural effusion, that's by definition stage 4, it's not curable. Okay, so on to some new stuff. So hopefully that was all a quick review of medical school lung cancer stuff. So pathology and molecular diagnostics. So lung cancer is still a histologic diagnosis. So we categorize lung cancer as either non-small cell, which consists of adenocarcinoma, large cell carcinoma, and together these are known as non-squamous histologies, and then squamous cell carcinoma. And then the other broad category is small cell lung cancer. And you don't have to be a pathologist to appreciate the fact that visually these look very different, and they are biologically different entities. They have different natural histories and have different responses to therapies, and that's why having the histology is very important. To draw an analogy, not all staphylococcus are the same, right? You wouldn't treat MRSA the same as you would MSSA or staph epidermidis. They're all different. But lung cancer diagnostics has gone further beyond just histology, and now we're going into more molecular studies, which is critically important now for clinical decision making. So the first thing I want to talk about is PDL1. It stands for Programmed Death Ligand 1, which is a protein expressed on the cells of both normal and malignant cells. And it's important because when PDL1 binds to PD1, which is expressed on T lymphocytes, it actually inhibits the T cell, prevents activation. And so that T cell remains quiescent, and kind of just moves along. And that is how the tumor can escape our immune system. You can see here on the right, the pictures, the PDL1 expression is on a spectrum. There can be no expression on the left, known as PDL1 negative, or it can be strongly expressed, which is on the right. There's a lot of brown staining through immunohistochemistry. And why is PDL1 important? It's because nowadays we have immune checkpoint inhibitors, also known as ICI, immunotherapy, IO. And the way they work is that these antibodies target the interaction between PDL1 and PD1. And so when you interfere with that interaction, the T cell is no longer inhibited. It becomes activated, it becomes enraged, and then it starts to mediate cell death, T cell mediated death. And that's how it can recognize the tumor and destroy it. A side note, the discovery of PD1 and PDL1 leading to immune checkpoint inhibitors was such an important discovery. It was actually awarded the Nobel Prize in Medicine in 2018. So that's one important thing that I look at now when seeing patients with lung cancer. The other very important breakthrough nowadays next generation sequencing. This really has changed the diagnostic landscape, particularly for non-small cell. You might have heard of the term personalized medicine or precision oncology. So this is what it's referring to. And what NGS is a technique that's done in the lab that sequences the genome of the patient's actual tumor. So that's why it's personalized. And it's trying to detect variants or genetic alterations in their specific tumor. So they can detect single nucleotide changes, like change from a valine amino acid to a glutamic acid. For example, insertions or deletions of whole sequences, if there's amplifications of certain sequences, or fusion, like new chimeric genes that may have occurred. So why do we care about genes? Well, we have to remember that cancer develops because of genetic changes in proto-oncogenes or tumor suppressor genes that change a cell from being regulated to now being unregulated and having uncontrolled proliferation, survival, replication, and then invasion and metastases. So the key point is that when you can identify the driver mutation or the driver genetic change, then that provides a potential therapeutic target to be drugged. So I have 3 NGS reports I want to share with you in the next 3 slides. This is a lady that I was consulted on as an inpatient here at the General. At the Centenary campus, not that it makes a big difference, but anyway, so she had a biopsy of her right cervical lymph node, and it was adenocarcinoma of the lung. However, her NGS shows that it was positive for EGFR exon 20 insertion, and her PDL1 score was 1 to 49%. This is another patient who had a lung biopsy of the right upper lobe. Again, adenocarcinoma of the lung, but his cancer now showed EGFR exon 19 deletion with a negative PDL1 score. And this is a third patient of mine who has, you guessed it, adenocarcinoma of the lung, but his tumor showed a fusion gene of EML4 and ALK detected by NGS. So the point I'm trying to make here is that all 3 of these patients have metastatic lung adenocarcinoma. But at a molecular level, they're actually different, and they're driven by different gene alterations and protein products. And so the end result is that all 3 of these patients are actually on totally different agents for treatment, and each agent has their own unique toxicity profile. Right, so I just want to talk briefly about our changing landscape in early/locally advanced non-small cell lung cancer for the non-oncologist. So what this is referring to is stage 1 to 3 disease, so cancer that has not yet metastasized distantly. And there's a spectrum of options of things we can do. So if it's really small, localized stage 1, then the definitive treatment is surgery, just cut it out. Or if patients are very frail, then they can get radiotherapy. If it's a bit larger, then the mainstay of treatment is still surgery. You cut it out, but because it's larger, there's higher risk of recurrence. So then we would provide adjuvant chemotherapy afterwards to prevent or lower recurrence risk. But to tie it into the previous subject, now we know that if patients have PD-L1 expression, we can actually add immunotherapy to further improve their outcomes. Or likewise, if they have an EGFR mutation, a specific one, then you can add a targeted therapy, an oral pill called the EGFR tyrosine kinase, to improve their outcomes. And there's also data to suggest you can skip chemotherapy altogether and go to that as well. And within the last few months, the landscape is changing again even more. Now we're looking at giving patients chemo and immunotherapy together before surgery, called neoadjuvant chemotherapy. And thereafter, it's still kind of open for debate. There's a lot of data and research. There's a lot of research going on to figure out what we should do if we're giving all of our treatments up front before surgery. And if patients' disease is not resectable, say they have lots of mediastinal nodes or contralateral mediastinal nodes, then the definitive treatment for these patients is combination of chemotherapy plus radiation and then immunotherapy thereafter. So the whole point I'm trying to make here is that the diagnostic workup of lung cancer, including the molecular tests, are very important for us to select the proper treatment. And it's getting more and more complicated. So the approach really requires input from all three of us: surgical, medical, and radiation oncologists when it's a localized early stage disease. The other point I want to make is that there are so many more agents nowadays that are coming into play. So you can see here all the immunotherapy options like atezolizumab, nivolumab, pembrolizumab, durvalumab. These are all PD-1, PD-L1 inhibitors. And then you have your oral pills, the osimertinib and alectinib tyrosine kinase inhibitors. That are being used more and more frequently. And so you may see more and more patients in the hospital because of their cancer or their side effects from their treatment. So I want to focus specifically on osimertinib and durvalumab next, because these are very commonly used. So this is a paper from 2020, osimertinib in patients with resected lung cancer who have EGFR mutation. And so my first trivia question to you guys is, in your minds, you can come up with a number, but what percentage of patients will remain free of lung cancer 4 years out after their surgery? Technically in the studies after randomization, but for our purposes, we'll just say 4 years after their surgery, how many people are still free of lung cancer? So in this trial, they found that 70% of patients were still free of lung cancer if they took osimertinib for 3 years thereafter, compared to 29% with placebo. So we're having patients live longer and longer for sure on these agents with lung cancer. Similar question. The next one was, how many patients do you think will still be alive 5 years after their surgery for their lung cancer? And in this trial, it was found that 85% of patients will still be alive after they've had their lung cancer resected if they had osimertinib thereafter. So the vast majority of patients will still be alive and hopefully doing well. I get a lot of consultations sometimes, questions asking, when the patient presents to hospital, could it be related to the drug that they're on? And appropriately so. And so one of the things I do, if it's not something that I commonly see, is I do also look up the product monograph, because the list of side effects is very extensive and there are a lot of weird and wonderful things that can happen. So this is something that you can do as well that I find very simple, very helpful. I just type in the name of the drug and CCO for Cancer Care Ontario afterwards. And the first link you almost always get is this drug monograph. And I like it a lot because they do have categorized all the possible side effects by organ system. And they also have a blurb for the most common side effects and then specific mentions of unique side effects to watch out for. So for osimertinib, it says here that the most common side effects include diarrhea, rash, pruritus, dry skin, nail disorder, mucositis, anorexia, cough, dyspnea, fatigue, nausea, vomiting, constipation. So it's quite a list. I must say, in reality, it's usually pretty well tolerated, and a lot of these side effects I can manage as an outpatient. But like I said, sometimes there are very unique side effects to watch out for. So rarely you can get erythema multiforme, toxic epidermal necrolysis TENS, or SJS as well. You can get QTc prolongation and torsades de pointes. left ventricular dysfunction and congestive heart failure. And like many oncology drugs nowadays, interstitial lung disease and pneumonitis. So this is all spelled out quite well and simply if you Google the drug name and CCO. And this is something that I would do as well when I get these kind of consults, just to make sure. So next is durvalumab. So similar exercise. So this study was published in 2017. So it's kind of an old study now in our world of oncology. So this is looking at patients who couldn't have their lung cancer cut out because it was too advanced. So they had chemo and radiation and then immunotherapy. So the first trivia question for you guys to guess is what percentage of patients will have stable control of their disease 5 years out from their chemoradiotherapy? So in this study, 33% of patients' lung cancer was well controlled 5 years after their chemoradiation if they had immunotherapy. So again, we're looking at a subpopulation of patients who can do very well years later after treatment for lung cancer. And similarly, what percentage of patients will still be alive 5 years out from their treatment with chemoradiotherapy and immunotherapy? In this trial, it was found to be 43%. So patients are definitely living longer and longer with this disease. They are on treatment, so they have potential to develop more toxicities from this disease as well. And that's why I think it's important to be somewhat familiar with these agents or their side effects, or at least know how to look them up. So I'm not going to talk about the side effects of immunotherapy because there are literally conferences devoted to this topic. But I think the take-home point is that Cancer Care Ontario does have guidance document for all the possible immunotherapy-related toxicities that there are and how to manage them. So for example, this is pneumonitis. So you can grade the severity of the pneumonitis. It mentions what kind of supportive care and referrals that you need to do, how to start the corticosteroids. That is usually the mainstay of treating immunotherapy-related adverse events. But really with immunotherapy, I think most people do this already. It's always appropriate to consult medical oncology for opinion because you can really get a reaction of any organ system. You can get pneumonitis, hepatitis, colitis, thyroiditis, nephritis, encephalitis, and the list goes on. Okay, so talking about advanced or metastatic non-small cell lung cancer. So this slide is very busy, both intentionally and unintentionally so, just to highlight the point that it's now getting more and more complicated in terms of how to manage these patients. Gone are the days where we just give chemo to everyone. We're getting more specific, and that's a good thing, because the outcomes for these targeted agents are much better generally than chemotherapy alone. So you can see at the top left, if there's no targets, then you're really looking at that PD-L1 expression, whether you can give chemo alone. Oh, sorry. I'll just decline this for now. Sorry about that. Whether you can give chemo in combination with immunotherapy or immunotherapy alone. But if you do identify a target on your next generation sequencing, you have a number of agents that you could use depending on what that target is that is found. And most of these are actually oral drugs. They are what we call targeted agents. And that it's important, and we make that distinction in the oncology clinic because, there still is a stigma and a conception of chemotherapy. And, it's not unjustified. Chemotherapy is difficult. And so we make that distinction because the side effect profile is completely different. The mechanism of action is completely different. And so that is really important for patients. Patients on these drugs typically are not immunosuppressed at the same level. They're not neutropenic and at risk of developing sepsis and febrile neutropenia as they would on chemotherapy. The other point I want to make is that these mutations are not specific to lung cancer. We do NGS in other disease sites too. For example, on the bottom right, there's BRAF V600E. This is commonly seen in melanoma, and we actually use the same drugs, dabrafenib and trametinib. At the lower left is ERBB2, that's HER2. We use trastuzumab deruxtecan, which is an antibody conjugated to a chemotherapy in breast cancer. Fortunately, most of these targets are rare. Their incidence is in the single-digit percentages, but I must say there's an exception. So EGFR is in the literature in our Western society quoted to be about 15% incidence of all lung cancer. However, when you look in Asia, that's not the case. And that's reflected here in Scarborough as well, where I find that I have a lot of Asian patients, South Asian, Southeast Asian. And I would have to say in my practice, I actually have more patients with an EGFR mutation than not. So it's particularly prominent in patients who are lifetime non-smokers of Asian background. There's no point going through each of these drugs. They are fortunately not too commonly used at the moment because these are rare mutations, but I do want to talk about lorlatinib because I do have one patient on it, and knock on wood that he does not show up in hospital. So lorlatinib, again, you type it in lorlatinib CCO and get the product monograph. The most common side effects are increased cholesterol, triglycerides, edema, weight gain, peripheral neuropathy, cognitive disturbance, diarrhea, cough, dyspnea, fatigue, and anemia. And you can see that some of these side effects are really not typical for conventional cytotoxic chemotherapy, right? You don't typically get hypercholesterolemia or triglyceridemia from chemo, hyperglycemia. You don't typically get psychotic symptoms like hallucinations, changes in cognitive function, mood, speech, or mental status, but you do with lorlatinib. And so I think when patients are on these drugs that are on the antineoplastic drugs, I think it's important to look it up just to broaden the differential in case we miss something. Likewise, you can get interval prolongation, AV block, and bradycardia. Again, not typical with cytotoxic chemotherapy. So just one last slide on osimertinib, just because I use it so much. We use it so much here in Scarborough. So this is looking at osimertinib in patients with stage 4 lung cancer. So the question is, what is the median overall survival of a patient with stage 4 lung cancer who has an EGFR mutation? So I don't know if this will surprise you or not, but the average survival of a patient with stage 4 lung cancer with this mutation is actually 38 months. That's more than 3 years for the average patient with stage 4 lung cancer. And of course, that means 50% of patients live less and 50% of patients actually live even longer than that. So our treatments are certainly getting better and patients are certainly living longer. But like I said, they're on these agents, so the potential for toxicity is also higher. And also, I do acknowledge that, clinical trial patients are not representative of the whole population. Generally, these patients have good performance status and not so many comorbidities that affect their function. So if you'll indulge me for just 2 more slides before I conclude, this is the survival curve for metastatic melanoma, so a completely different disease. This was published in 2014, and I've highlighted there in green that the median survival is less than 6 months for metastatic melanoma. And not only that, you can see that the survival curve basically plummets down to 0 by 30 months. By 2.5 years, all the patients have passed away in this cohort of patients. Fast forward to today, this is the survival curve of a study published in 2019, looking at the combination of nivo and ipilimumab, which are checkpoint inhibitors, and what a big difference these medications have made. The median survival with this combination of treatment is more than 60 months. So patients are now living with stage 4 metastatic melanoma for more than 5 years. And not only is that statistic amazing and what kind of inspires me in oncology, makes it so exciting, but you can also see that that survival curve does not plummet down to 0. In fact, that green survival curve is actually flattening out and plateauing. Which suggests to me that perhaps there is this subpopulation of patients who have long-term durable responses. And, dare I say it, maybe they're cured of melanoma, who knows? But I met one of these patients on this specific trial when I was doing my residency in Ottawa, and he's 9 years out with stage 4 melanoma. I think that's just amazing. So some takeaway points to conclude. So lung cancer is still the most commonly diagnosed cancer and responsible for the highest number of cancer deaths. So there's still ways to go. The diagnostic and therapeutic landscape is rapidly changing. So molecular diagnostics, and importantly, having enough tissue for molecular diagnostics is quite critical for optimal treatment selection and outcomes. And patients are on these novel therapeutic agents, such as immunotherapy and targeted therapy for longer and longer, and they have their own unique toxicity profiles that especially oncologists should be aware of, but I think the general practitioner too should be, as they are on these agents for longer and longer. And that is the end of my presentation. So I'll be on the lookout in the chat to see if there's any questions, but of course you're free to unmute and ask as well.
Hi, Victor. It's Allison. Great presentation. Thank you. I just wanted to say one other thing just to be cognizant of when these patients come in on these therapies is drug interactions. Lorlatinib is one that comes to mind. You have to make sure you're picking the right anti-cholesterol medication. There's CYP3A interactions to consider as well. That could increase the toxicity of the drug.
Yeah, absolutely. And we're so lucky to have an excellent team of oncology pharmacists to help us review those drug interactions. But of course, for sure, even when patients are admitted, very important to think about that as well. So we have a question in the chat. It says, does patient poor functional status preclude them from treatment with immunotherapy? So it's a really good question, actually, because immunotherapy is generally well tolerated. There can be horrific side effects that can occur. Unfortunately, it's a bit unpredictable. We don't have good biomarkers to predict who will have a bad reaction versus those who won't. That being said, it's still kind of a barrier to getting immunotherapy because it is still something that we can only give as an outpatient, and it's still IV, and they require blood work routinely. So, if it's hard for patients to come in and out of the outpatient setting every like 3 weeks for blood work, then it could be a barrier, unfortunately. And it's not something that we can give as an inpatient. That being said, I will say that we're a little bit maybe less strict about giving immunotherapy to someone who's more borderline, so before we would say, a strict cutoff is ECOG 2, if someone's ECOG 2-3, like if they're kind of on that borderline, we may still actually go ahead and push with immunotherapy just because it is better tolerated than chemo. Yes. And then kind of on a similar note, if I may extend that, so so a lot of the targeted agents I talked about are oral, actually. So for sure, I have definitely started an inpatient on oral osimertinib, and there have been very few problems with that. So it's mostly access is the big roadblock there, but certainly if we can get access to oral targeted inhibitors, we can give them even as an inpatient. Yeah. Next question. I read recently there are synergistic benefit by adding traditional chemo on top of targeted therapy. Is that true? And if so, are we doing that? Yeah, very timely, actually. So there was a recent study that was just published this year, for example, looking at the combination of chemotherapy plus osimertinib. And there's a lot of excitement about that because it did show some progression-free survival benefit compared to targeted therapy on its own. But of course, when you're starting to combine different agents together, your risk of toxicity and side effects is higher. So it is an option that I think will be coming to combine chemo with targeted therapy, but I think patient selection will be very important. Okay, I don't see any other questions. So thank you all for your time and attention. I'll put you guys all have my email. We're all in the same system. So if you have any questions, you can always email or epic chat me, and I'll be happy to talk or answer any further questions. Have a good day, everyone.